So, may I have your attention, esteemed faculty and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of the session. Good evening and a warm welcome to all the dignitaries present here. I am Shweta from Learned, serving as the allocated session assistant to ensure a seamless experience. Learned stands as India's most reliable digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Learned serves as a digital partner for this event hosted by National Neonatology Forum, and the focus of today's session is NNF Shine Week 1 South Zone. So let's begin today's session, for which I would like to hand over the session to Dr. Kumuta ma'am. Over to you, ma'am. Kindly proceed. Thank you.
Good evening, Sweta, and thank you. Good evening, Dr. Surender and Dr. Tapas. I'm very happy to be part of this important endeavor of NNF and also to host this first session. Thank you. Shall we start?
Yes, sir.
Will you share the screen or should I share this? Will you share or should I share the PowerPoint?
Ma'am, you should be able to share.
Ma'am, the option has been
Yeah,
enabled,
I'll
ma'am. You can
try.
share screen, ma'am.
Okay.
Yes. Yes.
Is it
Yes,
visible?
ma'am.
Okay. Thank you. So this is the first week session on neonatology forum Shine. That is the short course in neonatology. I'm really happy that this course has been really launched and taken off. And I welcome all the postgraduates who have joined this session. So let's start the day with a quiz. Others are joined. Sweta?
How many have joined,
Okay.
Shrita?
Sweta, how many have joined? Okay.
Just
Surinder,
kidding.
do I wait for the response
No, no.
or do I just
Please
continue?
start, ma'am. Please start.
Ma'am,
Yeah.
please start. Please start.
Okay.
Tapa. Oh.
So, can anyone identify what this is? Could you answer? Okay. So you can,
Tapas, you'll have
yeah.
Tapas, just coordinate with Shweta to make it little interactive as Madam is
Ah,
intending to. That will be more fun. So if that is the case, so please ask Shweta to allow hands and how many participants are there
So
for
there
all of
are
us to.
now 90 participants who are
Oh,
watching.
that's great. That's
ah.
so.
Allow them to answer.
To put a question and answer also in some chat box. Where do you
Yeah,
want them?
please ask them to respond in chat box.
Sir, whatever
Okay.
questions I will be receiving, I will paste in the chat box, sir.
No, see, ma'am,
Okay.
this question, right?
Okay. I'll do it. Okay. Thank you.
Yeah.
So they don't respond immediately. That's okay. So you can see erythematous lesions of the trunk and the abdomen, and in the back also you can see also central pallor and erythematous tissue. So all of us know what this is. This is erythema neonatorum, or earlier we used to call this as erythema toxicum, but we would prefer to call it as neonatorum because it's not due to any toxic effect. And it usually appears in the second or the third day, most often in the term neonates and bigger weight babies, and usually starts in the face and spreads down the trunk and the extremities. Though the exact cause is not known, and there is a postulation that it is an immune response to microcolonization of organization in the skin follicle. That is one hypothesis, but conclusively it is not been told as a cause. And it disappears spontaneously after 2 to 3 days. So many mothers get worried looking at that because it's big blotches of red patches, and so they get very worried. And we have to reassure the parents that this is a benign condition, doesn't need any specific intervention, and usually disappears into 2 to 3 days, at the most by 7 days of life. The next quiz is you can see certain skin lesions. with yellowish spots or pustules, and all of us know that it is milia. So these yellowish white spots seen in the face, especially over the nose and the face. If you want to see, I can show the slide again. Now you see over the nose, in the cheek, right cheek, in the chin, everywhere you can see small, small spots of yellow and white. And this is again due to retention of sebum. It's a skin condition seen in almost all babies, and it this also resolves spontaneously. We need not do anything about it. Many people tend to apply so many lotions and creams on the skin. It doesn't need to be done. Then you look at the eyes. There is a red triangular patch, especially on the medial side of the right eye. And this is nothing but subconjunctival hemorrhage. This is a semilunar arc of hemorrhage at the subconjunctival level, and this could be seen in normal babies also, but sometimes most of the instrumental deliveries also we tend to see this. And again, we need not do anything, but it needs a lot of reassurance. Again, when the mom sees sudden red patch in the eyes, she gets worried. So it resolves in a few days without leaving any pigmentation or any scarring, anything. So these three conditions are what we call it as deviations, which we see in the normal newborn examination. And though it appears very frightening, but we should reassure that these conditions would resolve without any intervention, and we should be very, very careful in making the correct diagnosis. And again, during postnatal rounds, you find a baby's temperature to be 36.0 degrees Celsius. And do you think that this baby needs to be shifted to an ICU for IV fluids and further care? And first of all, we have to, this is hypothermia, because any baby who has temperature less than 36.5, we label it as hypothermia. And also we have to classify the degree of hypothermia. In this is 36. So we would call it as mild hypothermia. And so cold stress, this baby doesn't need to be admitted in an ICU. What that baby, if the baby doesn't have any other symptoms of danger signs or any infections, this baby could be looked after in the postnatal ward, and the baby can receive skin to skin contact, and especially kangaroo mother care. And after half an hour to 1 hour, you recheck the temperature. Once the temperature comes up and baby is active, alert, and feeding, then we need not shift this baby. The main problem is in this mild hypothermia, and if there are no associated danger signs or any signs of any other illness, then this baby can be looked after in the postnatal ward itself. Okay, now we go to the topic of the week, and the first topic all of us know is a care of the normal newborn. So, how a normal newborn should be cared soon after birth. And we know now in our country, most of the deliveries are institutional. So, across the country, it is moved towards 95. In some of the states, it's as high as 99.5% or nearing 100%, especially Kerala, Tamil Nadu, Maharashtra, and all are having very high institutional delivery. So, the care of the normal newborn becomes the mandate of our health workers, because the mothers come to us with great faith. So, how do we take care of this normal newborn? First of all, we should know who is a normal newborn and what are the problems even a normal newborn, or anticipate certain issues, and then be prepared how to handle this baby. So the learning objectives in this lesson would be providing care of soon after birth. So once the baby is born, we assess the baby, and if our assessment is this baby is a normal newborn, then what care has to be given. And again, the second important thing which we do is screen babies for visible defects. So if there are any visible defects and that defect needs immediate intervention, then we have to give attention or pay attention to that. And number three objective would be providing appropriate and adequate postnatal care for normal babies. Always, when we have normal babies in the labor room, we need to have a person, especially with a pediatric training. It could be who can look after the newborn to provide essential newborn care should be present. It could be a health worker, it could be a nurse, or it could be a doctor. And all of us know that at different levels the deliveries are occurring in our country. It could be in a primary health center, it could be in a sub district hospital, it could be in a district hospital, or it could be in a medical college hospital. Wherever the delivery occurs, definitely we have to assign one person, one healthcare worker for looking after the baby separately at the labor. So, this is the mandate which all of us have to provide. That person need not be pediatrician or neonatologist always. That person could be any health worker who has got skill birth attendant training. So this is the mandate which we have to provide, and we will see what is the objective, how are these objectives we can fulfill once in the labor room and postnatal ward. So, birth is a crucial period of transition, all of us know. And most of the babies do this transition from in utero life to ex utero fairly smoothly. Nearly 90% of the babies do this transition smoothly. Only less than 10% of babies may need some assistance and they may have problem. So what is the effective care at the birth? So we need to anticipate problems as I told you earlier, and also provide support to ensure stabilization. So that support could be in personnel, in equipment, or the other supportive services also. And all of us know that only 10% of the neonates need or require resuscitation and can be safely and the rest, that is 90%, can be safely transferred with the mothers in the postnatal wards. So they can go to the postnatal ward with the mother. So, what do we do soon after care at birth? So, as I told you earlier, the trained health worker in the neonatal resuscitation should be present at the time of birth, and it should happen to all birth, including vaginal births. It is not only cesarean section who needs a trained person, but also vaginal birth or instrumental delivery also they need to be present. And babies who don't need resuscitation, that means those babies who have spontaneous breathing and transit well with good cry and activity at the time of birth, should be placed on the mother's abdomen, first prone, even before the cord is cut. And this baby, once the cord is cut, then the baby is moved to the abdomen. And this early skin to skin contact is the most important intervention in prevention of neonatal mortality. This skin to skin contact, which is provided soon after birth, which is also part of the Lakshya program, because the obstetricians also get trained in Lakshya program, and they are aware that the baby soon after birth should go to the mother's abdomen for early skin to skin contact. And all of us know this skin to skin contact has very many advantages. Number one, it reduces the hypothermia. Number two, it has colonization of the commensal bacteria from the mother, and we do not have any hospital acquired bugs colonizing on the skin of the baby. Number three, the incidence of hypoglycemia is supposed to be much less in the babies, very, very less, and highly reduced in the babies where there has been early skin to skin contact. Again, when we say skin to skin contact, this skin to skin contact is not just a few minutes where the baby stays there and then once we cut the cord, we take the baby elsewhere. No, if the baby is stable, and because we are dealing with normal newborns, these babies have to remain in skin to skin contact at least for 1 hour or even during the transport of the mother from the labor room or labor bed to the postnatal bed, this baby can go in skin to skin contact with along with the mother. So this just putting the baby onto the abdomen and then separating the baby from the mother after feeding is not the practice which we want to be done. So it has to be prolonged, and then it should be at least for 1 hour during the first initial period of time for all term babies or even preterm babies who are stable. And again, the next important intervention we do is breastfeeding should be started within an hour after birth. So that means we don't wait for at least hour. See, we have to do the early initiation of breastfeeding soon after birth. As soon as the baby's cord has been cut, after 1 to 3 minutes, then we have to initiate breastfeeding. These two interventions together, the early skin to skin contact and early initiation of breastfeeding, which offers the best start of the life to the baby, that is, with colostrum feeding, we can reduce the neonatal mortality by 22.3%. That means a simple intervention of breastfeeding early, that is within 1 hour, and initiating skin to skin contact and remaining at least there for 1 hour has given an evidence that we can reduce the neonatal mortality by 22.3%. So at least quarter of the neonatal mortality can be reduced by this simple intervention, which we have to see that we not only tell our health workers but see that it is practiced in our labor rooms across the country. So you can see these nice pictures which shows skin to skin contact has been established soon after birth, and you can see a nice alert baby there. See, you open a nice alert baby with a good reflexes. You can see a nice flexion there, and the next step is only cutting the cord only after 1 to 3 minutes. And you know, this delayed cord clamping is very, very essential, not only for placental circulation, we know that, and also it decreases the anemia of infancy, and also it increases the iron stores in the liver. So, and this important intervention is beneficial even for preterm babies. So, if a baby is stable, whether it is a term baby or a preterm baby, we have to wait for the cord cutting only after 1 to 3 minutes. So don't do it immediately. Get the baby onto mother's abdomen and then please clamp and cut the cord only after 1 to 3 minutes. And then the third step would be immediately initiate breastfeeding, and always, as I told you earlier, keep the mother and baby covered and observe breathing and color while the baby is in the mother's chest. And there is no need to do unnecessary suction of this baby when the baby is in the abdomen. In case if there is any secretions you could see, you could gently wipe with a gauze piece. Unless it is copious, there is no need to do the suctioning there, because this suctioning gives a very negative experience for the baby. It could be sometimes if you use a mechanical suction, that is electrical suction or a vacuum suction at high pressures, it can also cause mucosal injury in the mouth, and it could be giving very bad experience for the feeding of the baby. So there is no need to do suction, and gently you can wipe the secretions unless it's very copious. Routine suctioning is not recommended. So, what do we do once we cut the cord? The cord should be kept clean. There is, you can see again this picture where the baby is in continued skin to skin contact with the mother, even if, when they are giving the episiotomy. You can see the baby and the mother are together, and it also improves the bonding. All of us know that once a mother has waited for 9 to 9 months to get her baby, and she would be happily bonded with her baby once we put the baby onto her chest. Then the cord has to be kept clean, dry, and free of any application. So there is no need to apply any antiseptic or anything. So cut the cord and just leave it. If there any blood is there, please gently dry it and leave the cord open and dry. No application and no dressing. An infant should be weighed only after 1 hour. So this baby has to be remain in the mother's chest for skin to skin contact, and you please don't separate the baby for weighing sake. It can be done after 1 hour, and so there is not much changes of weight within that 1 hour, and so the baby would birth weight would be okay. So please weigh the baby only using a electronic weighing scale if possible. And also we can give even vitamin K, they say after 1 hour, or it can be given when the baby is in the mother's chest for skin to skin contact. And we have to give 1 milligram uh, injection vitamin K I. And if the baby is less than 1000 grams, what we give is vitamin K 0.5 milligrams intramuscularly in the anterolateral aspect of the thigh. You should be very careful only to use vitamin K1. Most of the institutions do have vitamin K1, but when we do for all these mentoring visits, we do see some of the hospitals having K3. So see to that vitamin K is the appropriate vitamin to be given intramuscularly in the anterolateral aspect of the thigh. So, baby identification. See, this is also very, very important because most of the mothers or the family members are very anxious to know what baby they have got and how is the baby. So, and communication of all these details is very, very important. And not only to relieve their anxiety, but they have a right to know happening with the mother and the baby. So the ID, there are also many hospitals which are using electronic ID, bands, with all that thing. But at least we should have a basic ID which has the name of the mother and the father, and the hospital registration number, date of birth, and the gender of the baby. Very, very important. And birth weight of the infant. So these are the identification details you should have. And many a time this identification being scrupulously done, meticulously done, would definitely help us in lot of dangers where switching of babies and all these things, if happens in the postnatal ward, we could defend ourselves. Okay, so identification is equally important, and this information has to be communicated to the parents. So the communication of that is very, very important, and showing the baby to the mother and also to the family members also is very important. Another point now, even Lakshya promotes that having a birth companion, that is during the time of delivery, identified family member by the mother stays along with her during delivery, during which time she also knows how the mother has undergone problem and whatever interventions have been done to the mother and the baby, and she also helps us in continuing the breastfeeding and skin to skin contact. If the nurses are very busy, the health worker is busy, that she can't provide, I mean, even spare time in a busy labor room, then once everything is stabilized, the presence of birth companion really helps us, and they monitor the infant when the baby is on the chest, and they also assist in initiating breastfeeding. So in that way we not only educate the mother, but we also can educate one family member on early initiation, how to position the baby and all that, if we allow a birth companion in the labor room. Okay, so this is care at birth, and our second objective is to screen the newborn for visible defects. So, the examination at the time of birth is very, very essential, and for this sake, you need not separate the baby away from the mother. So, still, this examination could be done in the mother's chest. Gently, we can just turn the baby and look at head and neck first. So RBSK also gives us a nice chart of all the visible defects which is seen and every labor room. So this is the RBSK chart, which I feel all the hospitals should have so that any health worker who examines the baby from head to foot, she would be able to identify the visible defects. So, first examination of the head and face, we look at the fontanelle and the facial appearance, any dysmorphic features, and especially if the head is large or small. So, obvious microcephaly or obvious macrocephaly. And apart from that, we might take weight, length, head circumference, and also gestational age at least approximately, looking at the breastbud, genitalia, and the skin, ear, lobule, elasticity, and all that, we could come to a rough estimation of a gestational assessment. If the baby is preterm, of course, we would be scoring them with new Ballot score. Then overall observation of the movements and tone, very, very important. Alertness, activity, and overall movement. Any restriction of movement on one side, either in the upper limb or in the lower limb, that will tell us there could be a problem in the bone, there could be problem in muscle, or there could be a problem in the nerve. Then coming to the head and face specifically, the head fontanelles we are looking for wide open or whether it is a small fontanelle, whether posterior fontanelle is open. And all of us know that if there is a posterior fontanelle open, then we should look for conditions wide open hypothyroidism. If the AF is also wide open, not closed, and then facial appearance of dysmorphism, like upward slant of the eyes, epicanthic folds, hypertelorism, depressed nose, and all that are dysmorphism, which can tell us that this baby could be trisomy. Then look at the eyes, especially red reflex. You may not do it at the time of birth, but at least before discharge, the child should have undergone the red reflex. But oral cavity has to be examined, especially when the baby is crying. We can shine a torch and look into the oral cavity, looking for cleft palate, especially. Lip would be very obvious, but we have to look at the palate. And if lip is there, we always look at the cleft palate, look for palate cleft. But if there is posterior cleft palate, then we would have a tendency to miss unless we examine the oral cavity. And of course, central cyanosis, we would look at the color of the baby, whether the child is pale pink or blue. Then coming to the other skin examination color, if we could have pallor if the baby is especially in shock, if mother had any antepartum hemorrhage or there was some fetomaternal transfusion. So those things can produce anemia. And also if the baby is older, then we will have jaundice. And if the baby in SGA baby, small for gestational age baby, you can see plethoric baby or hyperemia, child would be red instead of pale pink. So these are the things we have to see in the head and face. And then coming on to the neck, obvious swelling is there, then we will know whether it could be cystic hygroma or any thyroid swelling. Is that you have to look at. And then chest, we are looking at the respiratory rate, any retractions, and especially we have to look in the chest, the impulse, apical impulse position. So if you see the apical generally would be central or little onto the left side. But if you see the apical impulse on the right side, it is very, very mandatory. We rule out two things. One is diaphragmatic hernia, because most of the time diaphragmatic hernias are on the left side, and so they will tend to push the mediastinum, and you would feel the apical impulse on the right side. And also, of course, we should look for dextrocardia with true inversion. So that is also another thing. But what is an emergency if you have a apical impulse which is shifted to the right side is diaphragmatic hernia. Of course, X-ray would definitely confirm if there is any diaphragmatic hernia. Then coming on to the abdomen, again scaphoid abdomen you might see in diaphragmatic hernia, or in SGA babies when they pass large meconium you might see the scaphoid abdomen. And also you look for hepatosplenomegaly and kidney swelling, but much more is only you look for hepatosplenomegaly. Again look at the limbs. So limbs obviously we look at the number of digits, any digits missing, polydactyly, how it is polydactyly, it is whether postaxial or preaxial. So all that we might be looking at. And also we look at the genitalia, very, very important. And especially the anal opening, you look at the patency. But there is no need to put a rubber catheter or any catheter into the anus. So you just look for an opening. If there is obvious opening, you wait for the meconium to be passed. Sometimes even meconium child would have passed during birth itself, which you could see. And also uh, look for urethral opening in case of a female child also. But most of the time, also we have to not to forget the back and the midline. Midline, any obvious swelling like meningomyelocele, meningocele, sacrococcygeal teratoma, all that have to be examined. But see, it may take for me about 5 to 10 minutes to describe each of this. But if you routinely start looking for this, then this examination for looking for visible defects does not take much longer time. So every time a person who goes to the labor room have to look for all these visible defects. And also hip dysplasia, though we may not do it on day one, at least before discharge look for it. And also we should look for femoral pulses, and especially at least before discharge. But we are also now currently doing for identifying critical congenital heart disease pulse oximetry screening, either doing the pulse oximetry in the right limb and the lower right upper limb and lower limb, and comparing for that. That is an important test we are now advising. At least even RBSK team is all, RBSK also advises us to do the pulse oximetry screening before discharge, at least at 24 to 48 hours, so that we would not miss critical congenital heart disease. Okay, so the defects, as I told you, it has to be looked at birth. But even if this looking for defects gets skipped, the RBSK teams are they have a mandate. They have a mandate to look at the baby, newborn baby, before 6 weeks at the home as a home visit, getting the information from the Anganwadi worker. So if any birth defect gets missed, this early examination by the RBSK doctor at home also would help us identify any missed defects. As I told you, you could see here big hydrocephalus, microcephaly, anencephaly, and also you can see encephalocele and meningomyelocele. So, like this, we can see many defects, and this chart should be visible. You see, you can see limb defects here, and you can see a bladder defect here, urinary tract abnormality, a prune belly baby, and also you can see a Down's baby with typical dysmorphism, and you can see single palmar crease, and there is a large gap between the great toe and the second toe. So these please familiarize with these photographs. They are very self-explanatory, and each of this can be taught to every postgraduate. And then whenever you go for this resuscitation and taking care of the baby at birth, you can have this chart and compare and look for visible defects. So, as I told you earlier, the communication with the family is the most important uh, thing which we have to do after examination of the baby and stabilizing the baby after birth. So they should know about the time of birth, birth weight, and gender and condition of the infant at the mother and other family members, and also they should be shown. Then also, though we are going to talk about normal newborn babies, there are certain high risk babies which we have to identify and whom we may sometimes admit in the NICU if when they have problems, or even if they do not have problems anticipated for anticipated problems. So we should know who are the at risk babies. Generally, babies who are less than birth 1800 grams, they do have problems of hypothermia, then metabolic problems, they have jaundice, polycythemia, all those issues. So for those issues, they have to be admitted. And same way, babies who are less than 34 weeks. So any preterm baby who's less than 34 weeks do have immaturity of the various organ systems, and so they may have problems like respiratory distress, uh, hypothermia, again metabolic problems. They may have PDA based on the gestational age, and so many problems associated with prematurity. So they are at risk and they need to have further care. And then babies with major congenital anomalies, as I told you, like congenital diaphragmatic hernia, and then a big cleft lip palate who may have a feeding difficulty, or absent anal opening, or a large back swelling with sacrococcygeal teratoma. All these are major congenital anomalies where you have to deal surgically and also counsel the parents. And again, babies who did not transit well and had birth asphyxia, who did not breathe at birth and required resuscitation, especially if you had given resuscitation for more than 1 minute with positive pressure ventilation, or added chest compression and required medication, those babies also have to be uh, taken care of and classified as at risk infants. And babies with breathing difficulty, that means babies who had respiratory difficulty, especially with chest retraction, and who have their respiratory distress score quite high, either by Silverman or if you do Downey score. If their score is high, then they're all called as a high risk, and these babies might need admission into SNCUs or NICU, as the case may be. So now we have looked at the care at birth. So those babies who transited well, only to summarize, needs delivery onto mother's abdomen, and then they have to have delayed cord clamping, and also only clamping and cord cutting after 1 minute, and they have to be initiated early breastfeeding. And number four, they should have prolonged skin to skin contact in the labor room and during transport also. Then we screen the babies for any visible defects, and if they have emergency surgical conditions or malformations which require immediate attention, especially congenital critical congenital heart disease, congenital diaphragmatic hernia, or ectopia VCK, or meningomyelocele, those conditions immediately require our attention. They have to be admitted. Then we take care of the babies in the postnatal ward. So the babies are transferred after 3 to 4 hours of observation along with the mother in the labor room, and they are transported to the postnatal ward or transferred. So we have to take care of the baby, and most of the babies who are delivered by normal delivery stay with us for at least 72 hours. In fact, government of India has given us guidelines, because for certain conditions like jaundice and critical congenital heart disease, all that manifests later, though the baby appears normal at birth, we should not be in a hurry to discharge them. Early discharge program like 24 hours, within 24 hours. So in fact, it is recommended that we make them stay for at least 48 to 72 hours before we discharge them. So we should have certain discharge criteria before we discharge them early. So that is why the government of India has given certain guidelines for how many days a baby should stay minimum. And of course, cesarean section babies stay definitely for 72 hours and little beyond, depending on the condition of both mother and the baby. Okay. So when the baby is in the postnatal ward, they have to have a postnatal rounds. This is very, very important. See, most of the babies delivered in sub-district and district hospital, maybe because of lack of doctors, they do not get everyday postnatal rounds. That means the postnatal babies, though they are normal and they have been roomed in with the mother, bedding in, they have to be looked after at, or at least rounds has to be done daily and minimum 2 times a day. This is very, very, very important. And this may not happen across the country, but as pediatricians, as pediatric postgraduates, you should realize the importance of monitoring these babies in the postnatal ward, because they do get into certain problems which we have to monitor, and if monitored properly and proper interventions are taken, we could avoid many of the morbidities happening in these babies in the postnatal period, and unnecessary admissions to the neonatal unit can be avoided. So, what do we look at every day? We have to look at the cry, activity, and reflexes daily. And whenever, if the baby is sleeping when we go, we should ask the mother, how has the baby been behaving? Is the baby crying for feeds? Is the baby active when the baby is awake? And how are the reflexes? And if the baby is able to feed properly. So we should also look at the adequacy of feeding. See, in the first few days, most of the mothers would be saying that my milk is not coming, and so we have to tell them that they should feed the baby, because again, if, during early initiation of breastfeeding, teaching them proper positioning and attachment is the important work of the health worker. So both the family member also should be told how to help a mother to breastfeed. So if the mother is unable to get up and breastfeed due to episiotomy pain or a cesarean section, we should teach them how they can feed the baby in side lying position also. So this is very, very important. And also we should assess the adequacy of breastfeeding, whether the baby is able to take the feed and sleep well, and also is the baby passing urine. See, this early few days, the passage of urine would be about 2 to 3 times, and then the frequency increases once the lactation is established well. They should be passing at least 6 times in a day light colored urine. So this is what we have to look at in the adequacy of feeding, and seeing that the health worker should see that the mother frequently breastfeeds her child at least 8 to 12 times in a day. So these are things which you have to reinforce every day whenever you do the rounds. And again, maintenance of temperature is very, very important, especially those babies between 1800 to 2500 grams, whom we shift to the postnatal ward. You should see that their temperature is maintained. So, in fact, you can tell the mothers to keep even in skin to skin contact those 1800 to 2500 in the postnatal ward also, because the current WHO guidelines for initiation of KMC and skin to skin contact includes all low birth weight babies, which means all babies less than 2500 grams should receive KMC in the postnatal ward. And also we should teach the mother how to look for that. We will do it in the next chapter when we are going to talk about thermoregulation. But the least we can teach the postnatal mother is she has to touch with her dorsum both the feet, the hands, and the central part, which is the abdomen or the axilla. If both are warm, that means the babies are warm. If the central part is warm and the peripheral part is cold, that the baby is in cold stress, definitely needs skin to skin contact. And if after skin to skin contact also, if the baby's periphery is cold, then definitely a uh, more intervention is required, which she has to inform the doctor, and the health worker also should inform the doctor, where we have to really take the temperature of the baby and do proper intervention. And again, the most important another thing which we should monitor babies is for jaundice. We know that most 60% of the term babies and almost 80% of the preterm babies do have some degree of jaundice, and some also go for significant jaundice which may require phototherapy. So monitoring for jaundice is very, very essential in the postnatal rounds. So that is why we say in the morning and the evening, because it is very dynamic. In the morning you would have seen the child would not be very highly jaundiced, but there could be rise in bilirubin. And evening, if you look at the baby, that child could be significantly jaundiced, requiring intervention. So this is very, very important. And also another important thing which we have to teach the mothers and the health workers in the postnatal ward is to identify danger signs. The danger signs like, first of all, decrease in activity, decrease in cry, child not able to suck properly, and child is lethargic, no normal spontaneous movement, and child is feeling cold or increasing jaundice, bleeding from anywhere other than umbilicus. There could be little bit blood staining. So if there is any bleeding, or if there is abdominal distension, if the child is vomiting green color vomiters, all that are certain danger signs which we have to tell them. And then if that happens, they should immediately uh, inform the health worker. And we also, when we are doing the examination, we should look for any danger signs present. Okay, so what is the most important another thing we watch during postnatal rounds is a baby loses weight. So the weight pattern, if you look at the term babies, the babies lose up to 10% weight loss. And this starts during the first 2 to 3 days. And most of the babies, term babies, regain their birth weight by the end of the first week. So this is due to in extracellular fluid loss. So these babies lose water, and preterms experience little higher percentage of weight loss due to the again extracellular fluid loss. And this is 2 to 3% weight loss and daily, and also it can go up to 10 to 15%. So they regain birth weight by the second week. They start regaining by 10 to 14 days. So we should be very careful whenever we do. And again, some of the units or some of the hospitals, they tend to do daily weight. But again, we should be very careful whenever we do daily weight. Preterm baby, the same thing has to be told. But if you see when it is again, you have to see to that the babies in skin to skin contact look good, do a good temperature regulation, and also see that the baby gets adequate fluid in the form of good breastfeeding. So this is what we have to see that, especially late preterm babies. So there they may be some feeding problems, and they may not be getting adequate fluid through breast milk. So we should see that they get assistance and support for breastfeeding, and also they should be in skin to skin contact so that we could reduce the percentage of weight loss in them. Then adequate feeding, as I told you earlier, signs of adequate feeding: passes urine at least 6 to 8 times in a day. That's what, as I told you earlier, don't look for this 6 to 8 times on the first few days. At least after second or the third day only, you will have this 6 to 8 times passage of urine, and it should be light color. and the daily weight gain in term babies is around 20 to 30 grams. This you should look for only after 7 to 10 days. Don't again look for it in the first week. And also the baby should be comfortably sleeping between feeds. If you keep the baby in the same bed close to the mother, most of the time after each feed they sleep very well without much disturbance. This part we have to tell. And again also we should encourage mothers to give adequate night feeds, because night feed is the one which increases the peak of the prolactin which happens during the night, and they have good mature milk coming. So from then uh, uh, lactogenesis 2, which is endocrine, moves to lactogenesis 2 3, which is autocrine, automatically by frequent feeding and especially night feeding. Their milk production would go very well, and they would have adequate milk transfer, and adequate feeding would happen to the babies. Then coming on to evaluation of jaundice. So all infants must be examined in the daylight for the jaundice. So in jaundice, first we have to look at when did the jaundice appear, and also we should look at the severity of jaundice. And again, as I told you, we are going to do postnatal rounds twice a day. So every time, morning and the evening, we should look for assessment of jaundice. Most of the units use this Kramer staging, that is, visual assessment of jaundice by looking at the skin color. But for skin color, it should be in broad daylight. Of course, when you see it in the evening, try to see it before the twilight happens. So you could see here, if the baby is jaundiced in the face, head, and neck, then up to the neck it is around 6. And if it is in the zone 2 of Kramer, which is in the chest up to the umbilicus, then it is 9. And if it is up to the knee, the serum expected serum bilirubin is around 12. And if it is up to the ankle, it is 18 to 20. If it is staining the palms and soles, it's definitely more than 15 milligrams. But some of the units do have transcutaneous bilirubinometer, and these transcutaneous bilirubinometer are quite reliable, especially if the child has not undergone phototherapy. And good machines like Draga machines are available, and if it is properly calibrated and if you know to use properly, we could use transcutaneous bilirubinometer for assessing jaundice every day. In fact, AAP also recommends screening for jaundice using transcutaneous bilirubinometer, because the available ones now currently are quite reliable. But again, when you do grammar staging, there could be a lot of subjectivity. So your assessment of jaundice up to which part of the baby, that is very, very important. It goes from cephalocaudal progression from face up to the palms and so. So when we assess, we should be very cognizant and have quite an experience in doing the uh, assessment of visual assessment by looking at the skin. That's why postgraduates, whenever they do the postnatal rounds, it is always better to get the concurrence. They can assess the jaundice up to which area, and also get the concurrence of this senior professor or assistant professor with whom they would be doing the postnatal rounds, so that they could acquire good assessment of jaundice without much of subjectivity. Then certain other, so in postnatal rounds, we are looking at the cry color activity, very, very important. Then we look at the breastfeeding, and we look at the temperature maintenance, and then also we look at the passage of urine and meconium. Again, passage of meconium also is very important. If the child doesn't pass meconium at all within 24 hours, we should be very, very careful why there is delayed passage of meconium. That we have to find out. Sometimes meconium plaques, especially in preterms and late preterms, could be the cause, or there could be hypothyroidism. The most important thing is we have to see whether the anal opening is there or not. Sometimes when there is a anal atresia and uh, vestibular fistula, especially in a female child, they can have the napkin stain. So that is why whenever you are asking for passage of meconium, don't ask whether the napkin was stained with meconium. With a fistula, that the napkin could be stained with meconium. So we have to always visually, especially at birth, look for the anal opening. So these are things which I want to reiterate that we have to do in the postnatal. Many a time, many of the babies, especially anal atresia, got picked up in the postnatal ward rather than at the delivery room. So this has happened. In fact, we have had referral in ICH even after 5 days from elsewhere. Anal atresia missed, and babies have come with severe abdominal distension and coming in a very colitis and very sick nature. So this is very, very important. Again, the other common issues we would be seeing is one is vomiting. Most of the time, it may not be severe vomiting. So some of the babies have a tendency to regurgitate, especially if the mother feeds a baby and immediately puts the baby in a supine position. See, because the sphincter is at the same level as the esophagus, and they have a little contraction is much less developed, so they may have regurgitation of milk from the stomach to the esophagus, and they may posset or spit out some amount of milk. So we have to be very careful. So that is why either you keep the baby in the lap little upright, or you can put the baby in the side lying position instead of putting the baby in the supine position soon after feeding. And then due to faulty technique of feeding and lot of aerophagy also, you can have vomiting, because after a few minutes, that is 10 to 15 minutes later, suddenly baby would regurgitate with a lot of air and then get the milk out. So the proper advice regarding the feeding and burping must be imparted to all mothers. But if you put the baby on the shoulder and burp, many mothers have a habit of keeping on tapping the baby. There is no need. Just keep the baby in erect position so that if any aerophagy is there, the baby would be able to burp it out. So this is simple measures you could tell. When we should also know when that significant signs of clinical importance of persistent vomiting and projectile vomiting. This is very, very important. So when the vomiting is very little, or in fact it is regurgitation, we can tell them the correct technique of feeding and how to position the baby soon after feeding. But if the vomiting is persistent, very projectile, it could be either bilious or non-bilious, then we have to look for some cause, especially in the abdomen. It could be any congenital malformation involving the gut, and it could be sinister reason for which the baby is having vomiting. Okay. Then, so we have to, if we have projectile vomiting, we have to think of conditions like congenital pyloric stenosis if it is non-bilious. If there is bilious, we can have malrotation and all atresias. So we should be able to look for investigations and workup of that baby. Okay, so the second common issue is stool pattern. So, as I told you, most of the neonates pass meconium within 24 hours after birth. So, the transitional stools, and all of us know that meconium is black, tarry, a little semi liquid stool. And this stool transit into golden yellow. In between, you might from black tarry to it could be greenish yellow, and then becomes golden yellow sticky stools passed by the breast. Then it is almost like a broken egg. That's what they say. And breastfed babies afterwards, really they have the golden yellow. And especially the breastfed babies, the minute they feed, they immediately would pass. That is because of the gastrocolic reflex. Some babies may have exaggerated gastrocolic reflex, in which, as they are feeding at their mother's breast, they might be passing stool. So there's nothing worrying. Sometimes transitional stools could be also very watery, passing even 7 to 10 times a day. As long as the baby is active, alert, and taking feeds, they need not worry. Sometimes these watery stools also could be due to predominant fore milk feeding. We should see that the baby gets both fore milk and hind milk feeding, so that the baby would go into regular stool pattern. So, and sometimes breastfed babies, because colostrum is supposed to be very good purgator, and again, they pass stools frequently. But on the contrary, some of the breastfed babies may not pass stools at all. It's almost as though 100% absorption, there's nothing for the baby to pass stool. So, this is not constipation. See, they may pass once in 2 days or once in 3 days also. As long as they are able to be active, feeding, there is no abdominal distension, there is no need to worry. We have to reassure, in fact, the parents. Many mothers get worried if they don't pass stools for 1 or 2 days. So we have to reassure and look for the abdominal examination if it is soft and the baby is fine. And if the baby is exclusively breastfed, no need to worry, and we can reassure those baby mothers and send them home. The next common issue we see is the excessive crying. So if you see, no, some babies might be incessantly crying, wanting to be on the mother's breast at all the time or wants to be carried. And they are always noisy, and especially during the night. Many mothers would come and say, okay, we had sleepless night, doctor. What do we do? So all these, some of the babies do have their routine. See, in the mother in utero, when the mother is wa- walking, so they take it as a rocking movements and they sleep. And the mother sleeps, they are much more active. So their diurnal rhythm has not set in properly. So they might be having this cry. So we should be very, very patient as long as the baby is active, alert. And we should identify what is this. Is this real hunger or some discomfort? See, there are many reasons, like if the baby wants to be carried, cuddled, or if the baby is snappy, is wet, they pass motion or urine. So all this discomfort also, they might be fussy and crying. So we should find out what is the reason. And also, the mother quickly learns also why this baby is crying as the days go by, which we have to see. But if they have gone home and come, no, sometimes ant bites we see, and some stings also we see. Sometimes they may have ear pain. So we should also examine whenever the baby is crying. All the time we should not say, okay, okay, you please keep on feeding, give skin to skin contact, baby would be fine. Do a good examination, find out any important reason or any omnious reason for which the baby is crying is not there, and then reassure and send the baby. So good head to foot examination again would be necessary to say that this baby is not crying because of any pathological reason. Sometimes, when the baby is wanting to pass urine, especially male babies, they may not be able to open the sphincter well. They cry, and then after crying and all, they pass nice stream, and then they keep quiet. So, all this slowly disappears as a baby grows older by 1 or 2 months. So, advice at discharge. Again, most of the time we advise or decide to discharge the baby is one, when the baby's temperature is well maintained. Number two, at least 1 or 2 supervised breastfeeding has been done very well, and the baby is not losing much weight. And also, the baby is not very highly jaundiced, not in the AP high risk zone or moderate risk zone, and that has to be done. And also we have done a pulse oximetry screening and other newborn screening tests. Most of the routine newborn screening to be done has been done. And also we could arrange a follow-up, postnatal follow-up for the baby at the uh, which is nearer to the home. All these criteria have to be fulfilled before we discharge the baby. So at least in the MCP card, the health worker's name would be there. Even if your parents are wanting, or some reason you are discharging early, you could call that health worker and say, we are doing the discharge of this baby, kindly follow it up. Okay, so this is how discharge is decided based on whether they are able to have a normal temperature, maintenance, they don't have any major issues, their feeding has been there, their passage of urine and meconium is all right. Otherwise, they are doing well and they are not in the high risk zone for jaundice, then we can discharge them. And what is the advice you want to give at discharge? This is very, very important. Each mother and the family should be taught on how to take care of the baby at home. This is very important, especially for mothers who are very young, primary mothers, mothers who had previous baby loss. They will be very apprehensive, and if they are living very far away from the hospital in which they have delivered, and they may not be able to come for follow up, all that we have to examine before how we give the discharge. Okay, so what discharge are we going advice are we going to give? So first important thing is temperature maintenance. So at all times they have to keep the baby dry with adequate clothing. This depends on the location in which they live and the environmental temperature, that is the season. If you are in summer months, at least one clothing, close cotton clothing and one cotton covering. But if it is winter months, at least two layer of clothing along with some coverage with woolen. So it all depends on the environment in which they are going to, how their home environment is. Second, breastfeeding advice. They have to breastfeed their baby every 2 to 3 hours on a semi-demand schedule. The most of the time we say unrestricted baby-led feeding. That means the mother should understand the cues for feeding. They should also understand early cues, which are baby just waking from sleep, opening the mouth, turning to this way, that way, and rooting and putting the hands to the mouth. These are early cues that the mother has to breastfeed, and she has to breastfeed every 2 to 3 hours. That means at least 8 times in a day. Then card care, we should teach them, ask them not to apply anything. They sometimes apply, used to apply, but nowadays mothers are quite okay. They don't apply anything, but they tend to apply things like talcum powder, boric powder, and some antibiotic cream and all. Tell them the card should be kept dry and open. No need to apply anything. And again, in the eyes, definitely many of the mothers tend to apply kajal, so which is not good at all. It could be causing infection to the eye also, and there is no need to apply any antiseptic ointment in the eyes. Very, very important. And also, we should ensure at discharge that the baby has the immunization. See, most of the hospitals give the hepatitis B, BCG, and OPV within 24 hours of birth. So, we should ensure, even if the baby is born on a Sunday or getting discharged on a Sunday, we should ensure that we have facilities for immunizing this baby soon after birth, or at least within 24 hours. Danger signs, as I told you, poor feeding, appearance of jaundice within 24 hours of birth, or yellow staining of the palms and soles. We know that these two criteria are the important criteria for calling jaundice as pathological. So it needs definite investigation, and the child may require phototherapy, or need be may also require exchange transfusion. So these danger signs to be identified, and then failure to pass meconium within 24 hours, or pass not able to pass urine even after 48 hours, undue lethargy, excessive crying, and then respiratory difficulty and apneic attacks or cyanosis. So these are some of the danger signs which we have to tell the mothers also, when they get discharged. And also we should look for these danger signs in the postnatal rounds when what we do twice a day. And then bleeding from any side, persistent vomiting, especially bile stained, and then diarrhea, loose stools, and drooling of saliva or choking during feeding. Especially this we would have looked for in the at birth itself. If the child has got esophageal atresia with fistula or without fistula, also we might have drooling of saliva and choking during feeding. Then seizures, evidence of superficial infections such as conjunctivitis, pustules, and umbilical sepsis. So, as I told you, we can go through the checklist before discharge. See, all the hospitals, I feel, should have a checklist, uh, uh, in fact, checklist paper where we methodically tick this before we discharge. Once the so ideally, the infant should be discharged after 48 hours, as I told you earlier, 48 to 72 hours. And one is infant is free from illness. Second has been immunized. Adequacy of breastfeeding has been established, and mother is free from any significant illness, confident to take the care of the baby, and mother be been advised regarding danger signs. So these are some of the discharge criteria which is has to be fulfilled before we discharge the baby. Follow up, actually, newborn follow up should be done in the well baby clinic. But please think most of the mothers, though we request them to come for well baby follow up, they tend not to come because when the baby is fine, they feel they need not come to the hospital in a crowded place waiting for it. So at least why we should come make them come to the well baby clinic, we should really stress during discharge and make them come. So that is very very important. Importance of follow up in the facility should be stressed to the mothers and the family. So for assessment of growth and development, and again early diagnosis of and management of any illnesses, and health education of parents. But if you can also tell a word or put in a word that if the mother is unable to come to the facility for the given time of appointment for well baby clinic, at least she can go to the community health worker, because actually the babies need are supposed to be looked at home visit in the home based newborn care program, where they at least have to have 6 to 7 visits in the first 6 weeks of life. So please tell them that they should why they should come to the well baby clinic, importance of follow up in the well baby clinic of the facility. But if they are unable to come, they can at least do this growth monitoring, and if they have any illness, they can go to the nearest community health worker for follow up. And also we should link and tell those community health workers that we are this discharging the babies, please have the follow up also. So this link with the community health workers of the facility would go a long way in identifying any problem early, especially breastfeeding or any problem that the baby has, like neonatal sepsis or jaundice, prolonged jaundice, and all those conditions can be identified early and can be treated. So I hope all of us have done this, understood the uh, care of the baby at birth. So three cardinal things we looked at: what we do in the labor room, and then how do we screen for the visible defects. Number three is what we do in the postnatal care, and how we what are the criteria we use for discharge, and what advice to give for follow up. So those are the five cardinal things we looked at. Hope if you have any doubts, please put it in the chat box. Then we would be able to answer it at the end of the session. Okay, so moving to the topic two. So the topic two is thermal control. So when we say thermal, what is thermal control? Why do we need to give thermal control for the newborns? Because newborns have certain issues in temperature control. So we should know certain things like what is the mechanism of heat loss and what is the concept of warm chain, then how to record body temperature and grade hypothermia, and how to prevent and manage hypothermia, and how to manage fever and advise a discharge. So these are the uh, topics under which we will take the sessions in the next few minutes. But so we know that neonatal hypothermia is one of the important causes of neonatal deaths. And so, what is neonatal hypothermia? It is lowering of the body temperature of the newborn due to certain handicaps, or it could be due to disease. So, we should know that it is an important cause of neonatal death. Okay, so hypothermia not only has reduction of temperature, but it can also lead to hypoglycemia. So, whenever there is hypothermia, there is to generate the heat in the body, there is increased BMR. So increased BMR means we have more glucose utilization, and we have hypoglycemia, and we have bleeding diathesis due to associated coagulation problem, and also we do have pulmonary hemorrhage, acidosis, metabolic acidosis, apnea. Again, when metabolic acidosis depresses the brainstem, we do have apnea and respiratory failure, and also it affects the cardiovascular system, which results in shock and eventually death. So what started as mild hypothermia can end up in profound shock, and also what is called as a grave injury to the newborn, and can result in death of the child. So we should not take lightly of hypothermia, especially at risk infants, which we would be talking about little later. Who are the at risk infants who could go for neonatal hypothermia? We will deal that in the later slides. So we should know why newborns are prone to develop hypothermia. I told you earlier that they have certain handicaps. Number one, they have large surface area. So because they have large surface area for a given body weight, so they lose heat. So they lose heat by exposure of the large surface area of the body, and also they have decreased thermal insulation due to lack of subcutaneous fat, especially preterm babies and small for gestational age babies do have reduced subcutaneous fat. So because heat production happens in the fat, so heat production, fat is a seat of heat production. So if you do not have adequate subcutaneous fat, then you have more proneness for hypothermia. Again, they have reduced amount of brown fat in the low birth weight infants and preterm infants. You know that brown fat is a very specialized fat which is present in the nape of neck, in the interscapular region, and around the great arteries, where the heat production happens primarily, and the heat is circulated in the blood circulation so that it reaches the peripheral tissues and the skin. So when you have a lack of brown fat, then you will have reduced heat production in the body, and so the baby also have lack of heat generation, and so you will have hypothermia. Next is lack of shivering. So we have two types of heat production in the body. One is shivering thermogenesis, the other one is non-shivering thermogenesis. So we adults or little older children have the capability of shivering, but a newborn does not have a shivering thermogenesis process. So all the heat production is through non-shivering thermogenesis. That is why, because they do not shiver and they can only produce heat through non-shivering thermogenesis, again they are more prone for hypothermia. And also the heat loss is very high. As I told you earlier, the baby loses heat by various four important processes. One is evaporation, the other one is conduction, convection, and radiation. Let us see what are these processes and how the baby loses heat through these processes. So, as I told you, the heat loss is much greater in preterm and SGA babies. Uh, the baby loses heat by evaporation of amniotic fluid from the skin surface. As soon as the baby is born, the baby is exposed to the external environment. Baby in the in utero is at around 37 to 38 degrees Celsius. When the baby comes to the environment, which could be, especially if it is in a AC theater, it would be around 24 to 28 degrees. And even a normal labor room might have about 28 to 30 degrees Celsius. So the baby rapidly loses heat because of evaporation of the amniotic fluid. Number two, conduction. That is, conduction is a process in which the heat loss occurs because of the contact with the cold object. That is, if a surface which is warmer gets in contact with a cold surface, the heat gets conducted from the warmer surface to the cold surface. So let us say the baby is a warm person. So if the baby is made to lie on a cold stainless steel labor board, so the heat gets conducted from the baby to the cold stainless steel board. That is why Lakshya today says that baby mother should deliver in a bed which is not stainless steel. There is a mattress in between. It's a poor conductor of heat. So even if the baby is made to lie on the bed, they will not lose. But what is most best to prevent this conduction is baby to be put onto the mother's abdomen. So if you put the baby onto the mother's abdomen, this conductive heat loss would be less because the baby would be in contact with the mother's skin rather than the delivery board. Next is the convection. So baby loses heat to the convective air current around it. So the air currents in which the cold air replaces warm air around the body. So around the baby's body, the if you have a open window, so the blast of air comes and replaces the warm air around the baby. And if you have an AC vent nearer the delivery place of the mother, then you would have a convective heat loss more. So that's why we have to keep the environmental temperature of the labor room at a stipulated temperature, which we will see little later in the warm chain. Then radiation, that is losing the heat to the colder objects which is around the baby. So if you have a colder solid objects in vicinity or the walls or somewhere, then the baby loses heat through radiation. So we know that the baby loses heat by four processes. Ones are evaporation through amniotic fluid, then conduction, if cold, it gets in contact with the cold surface, convection by cold air current, and radiation to a colder solid object. So you can see here in this picture conduction. So if there is contact with a cold surface like a labor board, uh, then the baby would lose heat here. Then evaporation from the amniotic fluid. This convection is a cold air current and radiation to a solid object. So that is why we should have a warm chain around the baby. So when we say warm chain, what do we mean by warm chain? A set of 10 interlinked interventions to minimize the hypothermia at birth. Likelihood of hypothermia at birth we have to do so that we maintain the warm chain. So this has to be done from birth. So at birth itself we have to do it. So we could prepare the warm delivery room to 26 to 28 degrees. So the room temperature of the delivery room, even if a cesarean delivery happens, that cesarean theater temperature we should really adjust while we are conducting delivery so that we do not keep less than 26 there. And again, warm resuscitation. So if the baby needs resuscitation also, so if the baby does not need resuscitation, the baby would go on to the mother's abdomen and skin to skin contact, abdomen and chest skin to skin contact. But if the baby needs resuscitation, we have to do the resuscitation under the warmer so that we don't allow the baby to go for hypothermia. Next, immediate drying. We said because of the amniotic fluid evaporation, then you can have. So, immediate drying and remove the wet linen. We after drying, we have to remove the wet linen. If you keep the baby on that wet amniotic fluid soaked linen, then again baby would lose heat because it's a cold surface. Then by conduction also it will lose what started as evaporation. If you leave the clothing, it would be adding on conductive heat loss also. Then number four, skin to skin contact. Again, skin to skin contact prevents conductive heat loss because the mother is going to be warm. Then breastfeeding. Again, breastfeeding not only allows skin to skin contact, but it also adds energy to the baby to produce heat. Heat generation also happens. Then we have to postpone bathing and weighing. As I told you already, we don't do weighing till even 1 hour. And in fact, most of the hospitals do not do bathing at all inside the hospital. They get most of the government institutions and many of the medical colleges are also not doing because whenever the baby is bathed, it is exposed to all sort of heat losses and also depends on the temperature of the water also. So what we have to do is clean the baby with a nice clothing and get all the amniotic fluid and the blood nicely wiped off and so that the baby is clean. That's all. And then appropriate clothing and bedding. Immediately soon after birth, we have to clothe the baby. So we have to cover the baby with a dress and also the head, especially the heat loss through head is very high. So we have to put a cap and also preferably socks and mittens for the baby. And if the baby is in the skin to skin contact with the mother, you wrap the baby and the mother together with the clothing. And then always do rooming in. I would say it is not rooming in also, it is bedding in. We have to keep the baby and the mother in the same bed so that always the baby is close to the mother and the temperature is maintained. Again, warm transportation. So in fact there are a lot of studies which show that babies who have been transported in skin to skin contact, both for during postnatal transfer or transport from the labor room to NICU, wherever they go, if you transport them in skin to skin contact, or if that is not possible in a transport incubator where the temperature loss would be less, then babies are received in a better temperature in the postnatal ward and the in the NICU or in the SNCU. Then awareness raising of the healthcare provider. In other words, health education of the health provider. I would say here add awareness creation for the mother also, because in the postnatal ward, once the baby is being shifted, she would be ready with all the clothing if the clothing is not supplied by the hospital. So the awareness creation of the health provider and the family would be the 10th step of this warm check. So to repeat, warm delivery room, temperature maintenance very important, resuscitation, and then immediate drying and removal of the wet linen, skin to skin contact, breastfeeding, postponing bathing and weighing, appropriate clothing and bedding, rooming in, warm transportation, and health education to the healthcare provider and the family. So now we have to do the assessment of hypothermia. How do we assess the hypothermia? So we have to do the temperature recording. So, of course, we use a digital thermometer for temperature recording, and the site at which we do the temperature recording would be axillary temperature. We neither do oral or rectal thermometer monitoring. Unless the baby has severe profound hypothermia, we don't use rectal. So normally we take temperature in the axillary area, and the temperature thermometer has to be kept perpendicularly so that the bulb of the electronic thermometer opposes against the roof of the axilla in a perpendicular way. It should not be kept horizontal like this. It should be kept like this perpendicularly into the axilla. And what is the normal temperature of a baby? Axillary temperature is 36.5 to 37.5. So you can see here in this picture also the normal range is 36.5 to 37.5. So, how do we grade hypothermia? So, any temperature below 36.5 is called as hypothermia. So, axillary temperature less than 36.5 is called as hypothermia. And if the temperature in even this temperature, if it falls between 36 to 36.4, this is called as cold stress or mild hypothermia. See, this you can see in this whenever we are teaching the health workers also, we can show this picture, and any temperature between 36 to 36.5 is cold stress, and moderate hypothermia is anything between 32 to 36 or 35.9, that is moderate hypothermia. And in any temperature less than 32 degrees is called severe hypothermia. But IMNCA and other WHO guidelines say that if you have temperature less than 34, 35.4 itself, then the baby can go into severe problems. So we should not allow that. Okay. So to again grade temperature, if the temperature is between 36 to 36.5, it is cold stress, and that is cause for concern. And if the temperature is between 32 to 36, this is danger. We have to warm the baby. So, and also if the temperature is less than 32, the outlook is very, very grave. Even any amount of intensive care at that point, really, it is very difficult for us to save the baby. So we should not allow babies to go to severe hypothermia at all. They need urgent skilled care, and it needs extraordinary intensive care for us to save those babies. So there are temperature recording, as I told you, axillary temperature. This is good as rectal and very safer, and we use the digital thermometer. And skin temperature, we measure by thermistor probe. Most of the time, the thermistor probe is we have from the warmers or from the incubator, and some of the multi-channel monitors also have a thermistor probe. But most of the time in any SNCU or an ICU, thermistor probe of the warmer or the incubator is used, and it is attached in the upper abdomen in the skin, and really little on the right side, and it displays it on the panel. So, and the third way in which we can monitor temperature is human touch. That is, abdominal temperature is representative of core temperature. So, the mother, as I told you earlier, the dorsum of the hand is used to monitor the temperature. She should feel the feet and then also feel the abdominal temperature. If she compares both the temperature, both are warm. And if she has a pink feet, then the baby is in the thermal comfort. That means most probably the temperature of the baby is normal within 36.5 to 37.5. So both the abdomen and the feet are warm and the feet are pink. Then the baby is in thermal comfort. If the baby has got a cold feet but abdomen is warm, the baby is in cold stress. If the baby's feet and abdomen are cold, then the baby is in moderate to severe hypothermia. So, as we told, moderate hypothermia, we need to do immediate intervention and warming of the baby. And of course, severe would need much higher intensive care. So, always we should maintain in the thermal comfort, and we should always teach the mother to do this human touch and find out, especially high risk babies, and they have to maintain the thermal comfort. And if identified cold stress can be treated, we will see how to treat cold stress and also to treat moderate to severe hypothermia in the subsequent slides. See, what are the clinical signs and symptoms of hypothermia? Again, as I told you, lethargy. The baby's activity would be less and they will have less than normal movements. They will be just lying without even having any activity. And also, sometimes they will be having irritability, especially in the earlier thing. Once they go into moderate to severe hypothermia, they would be too lethargic to respond to anything. But in the initial phase, they could be irritable, and they also have poor feeding. So they are not able to suck at the breast, and they don't feed very well, and they have poor weight gain, especially high risk babies like preterm, low birth weight. One of the important causes of poor weight gain is hypothermia, indolent hypothermia. So we should be very careful that those babies are having monitoring of the temperature daily. Then breathing difficulty, they may have respiratory difficulty, and especially due to acidosis. And severe hypothermia may manifest with hypoglycemia, scleroderma, DIC, and bleeding. So they go for hypoglycemia, metabolic disturbances like hypoglycemia and scleroderma. This is hardening of the subcutaneous tissue. And they also can go for disseminated intravascular coagulation due to a lot of coagulation derangement. And also this leads on to bleeding from various sites and also purpura. So they can have ecchymosis purpura also. So, what is the routine care? We already told you that prevention at birth. First, we are drying the infant and then covering the baby nicely, and we have to leave the baby in skin to skin contact, and also we have to do the breastfeed. These are simple interventions which can be done by any healthcare worker. And also, if we educate the care provider, the birth companion, or the family members, this will happen very nicely in the labor room and in the postnatal ward. And we can prevent occurrence of hypothermia. Next, kangaroo mother care, as I will be told earlier, uh, especially those babies who are at risk. As I told you earlier, the babies who are at risk are birth, preterm babies, low birth weight baby, birth asphyxia baby, growth restricted babies. All these babies are at a high risk for hypothermia. So they will have, especially these babies, also benefit kangaroo mother care. So we know the benefits of kangaroo mother care are innumerable. Of that, the thermal control is the most important thing because KMC produces thermal synchrony. That means the mothers and babies' temperature get synchronized, and the body temperature of the neonate is very well maintained in the thermal comfort. So it also increases milk production, KMC. It increases exclusive breastfeeding rates, and also it reduces the respiratory tract and nosocomial infections, and also improves the anthropometric measurements of the child, especially the head circumference of the baby along with weight and length. If we have a good head growth, we know that the cognitive development of the babies, especially for preterm babies, it's quite beneficial. And also it improves the emotional bonding. See, KMC not only can be given by the mother, other care providers. So the bonding not only happens with the mother, happens with the father and the family members. And also it reduces the duration of the hospital stay, and definitely the risk of mortality is reduced by 38 to 40%, and it improves growth and optimum long-term neurodevelopment. So, as I told you earlier, KMC is so innumerable and is one of the important intervention necessary for prevention of hypothermia. And even in cold stress, we can give KMC, and these babies will benefit from this. And even in treatment of cold stress, KMC would be very useful, and also during transport. And then management of mild hypothermia, it is 36 to 36.5. So supervised KMC, that is the management of. In fact, I had asked you a question there. When the baby is in mild hypothermia, should we shift to NICU for IV fluids? The answer is here. We would like to give only supervised KMC. If KMC is not practical, warm room. That is, keep the room around to 26 to 28 degrees using radiant heater or other heating device, that is room heater. Then cover adequately and replace the cold clothes. So if a baby is cold, then remove the cold clothing and then replace it with warm clothing. Continue breastfeeding, especially if the in mild hypothermia, the baby would be in a status of feeding. Breastfeeding is possible for that baby, so we can continue breastfeeding frequently, and then monitor auxiliary temperature every half an hour. After keeping the baby in KMC, you can sorry, monitor the temperature in KMC position itself till the baby reaches 36.5. Then hourly for the next 4 hours, and second hourly for 12 hours thereafter, and third hourly as a routine. So this is the routine to be followed for management of mild hypothermia. If the baby remains hypothermic 1 hour after supervised KMC, or if danger signs appear, sepsis should be suspected and treated accordingly. So you see a well covered newborn, head is covered, baby has a warm clothing, nicely wrapped in winter months, especially. You see, so wrapping of the baby, actually, there is a nice way of wrapping the baby so that we could cover all the parts of the body except the face. So we take a square clothing and we fold one corner, and that corner is kept in the top. So the head is kept there. We leave certain amount of clothing so that we can cover it as a hood. Okay. So after that, we take the right side flap and cover the baby, then the down flap, and then the left flap, so that you would get this portion of the clothing as a hood for the baby. So that is the way we have to wrap the baby nicely, and then also teach this wrapping to the mother and the family members. Then significant hypothermia, as I told you earlier, IMNCA and WHO calls any temperature less than 34.5, sorry, 35.5 as significant hypothermia. So what we should do to treat these babies? Again, the first important intervention is remove the cold clothes. If the baby's got any wet napkin, anything cold, replace it with warm clothing. Place the baby under radiant warmer with clothes, that is cotton clothing. There is no need that always people tend to think that babies have to be nursed open in radiant warmer. No, please, we can wear a cotton clothing when the baby is nursed under radiant warmer. We can cover the baby, including caps, socks, and mittens. Monitor the temperature and other vitals every 15 to 30 minutes. So, what are the additional things we have to do? Continue breastfeeding If the baby cannot breastfeed only directly, we have to express the milk. We can give it through palade or gavach feeding. Most of the time, if the babies are able to take palade feed or katori feed, that is small cup, is the preferred method by which we can feed. But if both is not possible, then you can add gavach feeds. In case baby has feed intolerance, then only we start IV fluids. Initially, if the babies cannot breastfeed, please give express breast milk through palade or gavach. And if the perfusion is poor, that is, if the baby has gone into shock, we are having CRT prolonged more than 3 seconds, or if you have hypertension, then baby has to be treated with fluid replacement. That is, we have to do the shock correction by giving 10 ml per kg of normal saline over half an hour. And then also, because we said they tend to have bleeding and coagulation profile problem, so we need to give injection vitamin K. And based on the oxygen saturation, we have to provide oxygen, or in fact, we can give CPAP also if the baby has got respiratory difficulty, or if it has short apnea but in between breathes well, we can also commence the baby on CPAP. And if the baby has got saturation less than 90, definitely some mode of respiratory support is required for the baby. And during this respiratory support, we have to give a FiO2 where we maintain the saturation around 91 to 95%. So if you are giving CPAP, always tune your FiO2 based on the saturations. Okay, so we know now that temperature, the newborns have handicaps of temperature regulation more because of their uh, only with heat production is through shivering, non-shivering thermogenesis, the lack non-shivering, and also they have high temperature loss because of the larger surface area, and they have less subcutaneous fat and brown fat. And we looked at the high risk babies who are preterm, vulnerable babies, sick baby, sepsis baby, in all that asphyxia. We should be very careful that their temperature. And as I told you, 10 interlinked interventions to maintain the temperature of the body, which is called as a warm shade, should be maintained. For mild hypothermia, we can try skin to skin contact and properly monitor the temperature along with breastfeeding. And if only there is no response, then we move to the higher level of management, like shifting the baby to the warmer and other interventions. If it is significant hypothermia, apart from the warmer, radiant warmer care, they might need express breast milk, then IV fluids, vitamin K, and respiratory support and oxygen therapy based on saturation. Okay. Then coming to the fever, that is environment temperature more than, not environment temperature, baby temperature more than 37.5. If the body temperature is more than 37.5 degrees Celsius, we call it as fever or hyperthermia. So, what are the common causes a baby has fever? Environment too hot. Most of the time in summer months like now, when the environmental temperature soars to 40 degrees or 38 to 42 degrees, then we do have babies having hyperthermia. Then babies being overdressed. We showed wrapping. So if they keep on wrapping with multiple layers, so that's why I said clothing should be appropriate to the environment temperature. Very, very important. We can't give unnecessarily too much clothing. And another thing, the uh, babies are kept in one bed which is insulated, which is used for carrying and all. If you put in that, wrap the baby and put the baby, especially in summer months like this, definitely they will go for hypothermia. So whenever you go to the postnatal rounds, or when the babies come to us for follow-up clinic, we have to insist on this clothing part. And the harms of overdressing. And then keeping a newborn too close to a heater. But here, this heater, whenever they are using room heaters only, it will be seen. And leaving baby under heating devices, that is radiant warmer or anywhere where the probe gets dislodged, or in an incubator the probe gets dislodged, and then the sensor senses it as low temperature, and so much heat is generated and the baby becomes too hot. So this also. And another important pathological cause is sepsis. So a baby who's got sepsis, one of the two manifestations we could see is either low temperature or it could be high temperature. So, how do we manage hyperthermia? So, first of all, we have to find the cause. If you think environment, temperature, and unnecessary clothing, then that has to be handled as moving the baby to a colder environment. So, if the environment temperature is very high, you can move the baby to a temperature where it is around 26 to 28 degrees, and using loose, light cotton clothing, single layer cotton clothing, and remove the baby from the source of heat. If the baby is under warmer getting overheated, then we can remove, and then once the baby regains normal temperature, maybe we can move it. If the temperature is more than 39, we can do tepid sponging, that is ordinary water, normal room temperature, whatever water we get in the normal tap, that is tepid sponging. And then give frequent breastfeeds. Because of the environmental temperature, there will be dehydration also, associated dehydration. So it's very important that we give frequent breastfeeds, and also ask the mother also to drink adequate fluids. That is also very very important. Only if the baby cannot breastfeed, we give express breast milk, either by spoon, palade, or by tube. And if the baby does not tolerate, only we give IV fluids. See, any increase environmental temperature, even with dehydration, the baby can be treated with exclusive breastfeeding and express breast milk being given by katori or spoon. Only if this is not possible, then we give IV fluids. And we have to measure the temperature of the baby hourly till it becomes normal. So this is very, very important. These simple measures would go a long way in reducing the, especially the environment and temperature first should be taken care of. And second important thing is adequate breastfeeding and fluid orally. Enteral feeding itself can prevent dehydration. Then workup of a hypothermic baby if infection is suspected. So if you suspect, see one important difference in clinical examination. If you look at the baby hypothermia with the environment temperature, the whole body would be hot, and the baby would be feeling red, little red. And if you look at the periphery and the core temperature, that is feet and the abdomen, both will be warm or hot. Whereas in a case of sepsis, the core and the peripheral temperature, there will be difference of more than 2 to 2.5. That means the temperature, that is core temperature in the abdomen would be hot, whereas the feet temperature or the hand temperature will be cold. So this is very typical of hyperthermia due to sepsis. So this is very important thing which you should know while we are examining the baby. And again, the other signs which you would see in a septic baby or a baby who's got hyperthermia due to sepsis would be undue lethargy, excessive crying, especially those with meningitis could be irritable also, associated seizures, poor feeding, persistent vomiting. More than persistent vomiting, they have poor feeding, poor feeding, and then respiratory distress, recurrent attacks of apnea, cyanosis, poor saturation dipping to 85s and even less than 80s, bleeding from any side, pustules, and sepsis. So there will be some focus of sepsis in these babies, like pustules, umbilical sepsis, or even limitation of joint movement with arthritis. You can see very hot babies coming because of septic arthritis. Sometimes it might be in the local area very hot, and also they may have generalized increase in temperature as fever. So definitely these babies need workup. When we say workup, they need the baseline septic screen, culture, and if you have any specific infections like septic arthritis or any abscesses, then we may have to take the pus and send it for culture. So that will tell us the septic screen and the specific blood culture and specimen culture like pus would tell what type of sepsis we are dealing with. And so, what is the desired and follow-up advice for prevention of hypothermia? Hypothermia. So, at home, ensure that the baby is adequately covered. See, especially these low birth weight preterm babies when they get discharged or sick babies, we have to tell maintenance of temperature is the most important thing. They can continue home KMC. That is very, very important. We have to say and continue exclusive breastfeeding. And always the baby should be with the mother, bedding in with the mother. And the baby's room temperature has to be maintained, as we said, 26 to 28 degree. And then well clothed, depending on the temperature around the home temperature, they have to do adequate clothing. And feet to be covered with socks and hands with mittens and cap, especially for extra care for low birth weight babies. I think these are simple interventions, though I have taken, I think, almost 1 hour for this session, but these are the two important lessons, and 90% of the babies come into this category. And if we take care of those 90% of the babies well, adequately when they are with us, and also when they come for follow up with us, and also link with the community so that they could be care, we can reduce our neonatal mortality to considerable percentage. And not only that, also we can have a baby without any morbidity, so that they have normal growth and normal development, and we can give good care of the baby. Thank you. If you have any questions, I would be able to answer.
Ma'am, so far there are no questions. So thank you so much, ma'am, for letting us host the session today, and thanks to all the delegates who have joined today for this event. So with that, we would like to conclude the session over here, and really looking forward to hosting all again. Thank you so much,
Mm.
ma'am.
Sweta, how many people were there?
Just a moment, let me check. Hello, ma'am. Earlier it was 145, and right now it's 95, ma'am.
Okay. Dr. Sushma asked me to say that they will be taking their assessment tomorrow or Monday. Uh, uh, Surender is there?
No, ma'am.
No. Okay. Okay. So they will be taking their assessment, which they will get the message in the group for which they should be prepared.
All right, ma'am.
So can we conclude the session?
Yes, ma'am. Sure, ma'am. Thank you so much.
Thank you. Can I leave?
Yes, ma'am. Sure, ma'am. You can leave.
Thank you.